Hi, today we will be discussing Chapter 29 on Disorders of Smell and Taste of Harrison's Principles of Internal Medicine. First, we will discuss the anatomy and physiology. Odorous chemicals enter the front of the nose during inhalation and active sniffing, as well as the back of the nose or nasopharynx during deglutition. After reaching the highest recesses of the nasal cavity, they dissolve in the olfactory mucus and diffuse or are actively transported by specialized proteins to receptors located on the cilia of olfactory receptor cells. The cilia, dendrites, cell bodies, and proximal axonal segments of these bipolar cells are located within a unique neuroepithelium covering the cribriform plate, the superior nasal septum, superior turbinate, and sectors of the middle turbinate. Each receptor type projects to a common glomerulus. The neural activity within each glomerulus is modulated by periglomerular cells. The activity of the primary projection cells, the mitral and tufted cells, is modulated by granule cells, periglomerular cells, and secondary dendrites from adjacent mitral and tufted cells. The axons of the mitral and tufted cells within secondary olfactory structures, which largely comprise the primary olfactory cortex. The primary olfactory cortex is defined as those cortical structures that receive direct projections from the olfactory bulb, most notably the piriform and entorhinal cortices. Olfaction is unique in that its initial afferent projection bypass the thalamus. Persons with damage to the thalamus can exhibit olfactory deficits, particularly ones of odor identification. Such deficits likely reflect the involvement of thalamic connections between the primary olfactory cortex and the orbitofrontal cortex. Close anatomic ties between the olfactory system and the amygdala, hippocampus, and hypothalamus help to explain the intimate association between odor perception and cognitive functions. Taste stunts are sensed by specialized receptor cells within taste buds, which are small, grapefruit-like segmented structures located on the lateral margins and dorsum of the tongue, roof of the mouth, pharynx, larynx, and superior esophagus. Lingual taste buds are embedded in well-defined protuberances termed fungiform, foliate, and circumvallate papillae. After dissolving in a liquid, tastants enter the taste pore, which are openings in the taste bud, and bind to receptors on microvilli, eliciting electrical potential changes on the taste cell, resulting in neurotransmitter release onto the first-order neurons. Taste information is sent to the brain via three cranial nerves, 7, 9, and 10. The axons of the projection cells enter the rostral portion of the nucleus of the solitary tract within the medulla of the brainstem. They then project to a division of the ventral-posteromedial thalamic nucleus via the medial lemniscus and then to the rostral part of the operculum and adjoining insula, considered the primary taste cortex. They then go to the secondary taste cortex, namely the caudolateral orbitofrontal cortex. The gustatory nerves are cranial nerves 7, 9, and 10. Although not technically a gustatory nerve, cranial nerve 5 shares primary nerve roots with many of the gustatory fibers and adds temperature, texture, pungency, and spiciness to the taste experience. Cranial nerve 7 innervates the anterior tongue and all of the soft palate. Cranial nerve 9 innervates the posterior tongue. Cranial nerve 10 innervates the laryngeal surface of the epiglottis, larynx, and the proximal portion of the esophagus. The mandibular branch of the cranial nerve 5 conveys somatosensory information such as touch, burning, cooling, irritation to the brain. The chorda tympani joins the lingual nerve, which is a division of cranial nerve 5 near the tongue, and carries parasympathetic fibers to the submandibular and sublingual glands. The greater petrosal nerve supplies palatine glands and influences salivary production. The ability to smell is influenced in everyday life by the following factors. Women typically outperform men on tests of olfactory function and retain normal smell function to a later age than do men. Significant decrements in the ability to smell are present in more than 50% of the population between age 65 and 80 years old, and in 75% of those aged 80 years old and above. Aside from aging, the three most common identifiable causes of long-lasting permanent smell loss are severe upper respiratory infections, head trauma, and chronic rhinosinusitis. Upper respiratory infections, such as those associated with the common cold, influenza, pneumonia, or HIV, can directly and permanently harm the olfactory epithelium by decreasing receptor cell number, damaging cilia on remaining receptor cells, and inducing the replacement of sensory epithelium with respiratory epithelium. The physiologic basis for most head trauma-related losses is the shearing and subsequent scarring of the olfactory phyla as they pass from the nasal cavity into the brain cavity. A poor score on the Glasgow Coma Scale and the length of post-traumatic amnesia is associated with higher risk of olfactory impairment. The smell loss associated with chronic rhinosinusitis is related to disease severity, with most loss occurring in cases where rhinosinusitis and polyposis are both present. A number of neurodegenerative diseases are accompanied by olfactory impairment. It can also occur in idiopathic rapid eye movement behavioral sleep disorder and in multiple sclerosis-related lesions within olfaction-related structures. Olfactory impairment in Parkinson's disease often predates the clinical diagnosis by a number of years. In Alzheimer's disease, poorer smell function associated with higher levels of Alzheimer's disease-related pathology. Smell loss is more marked in patients with early clinical manifestations of dementia with Lewy bodies than in those with mild Alzheimer's disease. The smell loss seen in idiopathic rapid eye movement behavioral sleep disorder is of the same magnitude as that found in Parkinson's disease and may be associated with narcolepsy. The majority of patients who present with taste dysfunction exhibit olfactory and not taste loss. This is because most flavors attributed to taste actually depend on retronasal stimulation of the olfactory receptors during deglutition. Taste buds only mediate basic tastes such as sour, bitter, salty, and umami. Impairment of whole mouth gustatory function is rare outside of generalized metabolic disturbance or systemic use of some medications. The following factors influence taste function: age, diet, smoking, use of medications, and subject-related factors such as release of foul-tasting materials from oral cavity, from oral medications, from oral medical conditions, transport problems of taste buds to the bud, damage to the taste buds, damage to neural pathways innervating the taste buds, damage to central structures, systemic disturbances of metabolism, iatrogenic interventions such as tonsillectomy, bronchoscopy, laryngoscopy, endotracheal intubation, and radiation therapy can result in selective injury to cranial nerves 7 and 9. Cranial nerve 7 damage commonly results from mastoidectomy, tympanoplasty, and stapedectomy, in some cases inducing persistent metallic sensations. Bell's palsy is one of the most common causes of injury to cranial nerve 7 that results in taste disturbance. On rare occasions, migraine is associated with a gustatory procedure or aura, and in some cases, taste stunts can trigger a migraine attack. Burning mouth syndrome is likely associated with dysfunction of the trigeminal nerve. The following are some of the etiologies suggested for this poorly understood syndrome. Certain medications and systemic disorders can cause both taste and smell alterations. Psychiatric conditions can also be associated with chemosensory alterations. Pregnancy is a unique condition with regard to taste function. There appears to be an increase in dislike and intensity of bitter tastes during the first trimester, and a relative increase in preference for salt and bitter in the second and third trimesters. In most cases, a careful clinical history will establish the probable etiology of a chemosensory problem, including questions about its nature, onset, duration, and pattern of fluctuations. Sudden loss suggests the possibility of head trauma, ischemia, infection, or a psychiatric condition. Gradual loss can reflect the development of a progressive obstructive lesion. Intermittent loss suggests likelihood of an inflammatory process. This slide emphasizes the points in the history that should be asked in order to aid in the identification of the etiology of the symptom. Neurologic examination should focus on cranial nerve dysfunction with particular attention to possible base or intracranial lesions. Visual acuity, field, and optic disc examinations aid in the detection of intracranial mass lesions that produce raised intracranial pressure and optic atrophy. The Foster-Kennedy syndrome refers to raised intracranial pressure plus a compressive optic neuropathy, and typical causes are olfactory groove meningiomas and other frontal lobe tumors. The otorhinolaryngologic examination should thoroughly assess the intranasal architecture and mucosal surfaces. Polyps, masses, and adhesions of the turbinates to the septum may compromise the flow of air to the olfactory receptors. Appropriate brain and nasosinus imaging also aid in the evaluation of patients with olfactory and gustatory complaints. Blood tests may be helpful to identify systemic conditions that may contribute to taste and smell dysfunctions. Quantitative smell and taste testing provides objective information. The most widely used of these tests is the University of Pennsylvania Smell Identification Test. Although electrophysiologic testing is available, they require complex stimulus presentation and recording equipment and rarely provide additional diagnostic information. Given the various mechanisms by which olfactory and gustatory disturbances can occur, management of patients tend to be condition-specific. Underlying systemic conditions should be treated appropriately. For most patients who present primarily with obstructive or transport loss affecting the nasal and paranasal regions, medical and/or surgical intervention is often beneficial. Antifungal and antibiotic treatments may reverse taste problems secondary to candidiasis or other oral infections. Chlorhexidine mouthwash mitigates some salty or bitter dysgeusias. Excessive dryness of the oral mucosa is a problem with many medications and conditions, and artificial saliva or oral pilocarpine treatments may prove beneficial. Other methods to improve salivary flow include the use of mints and lozenges or sugarless gum. Food enhancers may make food more palatable. Medications that induce distortions of taste can often be discontinued and replaced with other types of medications or modes of therapy. Proper oral and nasal hygiene, routine dental care, and smoking cessation are extremely important ways for patients to protect themselves from disorders of the mouth and nose that can ultimately result in chemosensory disturbances. This ends the discussion on disorders of smell and taste.